Dear friends, I will like to share with you few slides with which, if young orthopedic surgeons get ignited by the end of this session towards Ilizarov methodology, I think the purpose to some extent of my presentation will be met with. Dear friends, as all of us know, mind is not a vessel to be filled, but it is a fire to be kindled. So the young mind, young orthopedic surgeon's mind, they are just to be ignited. And once they are convinced, yes, this is also a method which should be adopted, then I think they will go for it and they will have it. They will learn it and they will apply it. Why should we learn these things? Ilizarov, support. There are patients. And few words about Ilizarov, most of us have heard about. Few words about the hexapod. Hexa means 6, pod means feet, legs. So there are 6 rods which are connecting 2 fragments. And if we change the length of these rods, we can either shorten them or lengthen them. And with that, the position of the fragments with respect to each other can be changed and the fragments can be brought to desired position. All these things can be done with Ilizarov without hexapod as well. But they have to be divided in different sessions. You have to apply hinges for angulation correction, then translation devices for translation, then rotational devices for rotation, all one by one. But these all the things can be done in a simpler way in one go with the hexapod. Without hexapod, either hinges or translation devices or rotation devices, and with hexapod, we can do all these things in one. Just to simplify, what do I mean to say by this? That if there is an ant and it is on the floor, it wants to go to the roof, first it will travel the floor, then it will travel the wall, and then to the desired position on the roof. Suppose instead of this, we have a wasp. The wasp will reach the point on the roof directly from the floor. So it will draw a direct trajectory. Similarly, hexapod also creates a direct trajectory from the present situation to the desired position. What it does, it saves time, simplifies the correction, and it is less strenuous to the regenerator. What does this mean? I will try to clarify these things in my next few slides. So, dear friend, let us enjoy Ilizarov Safari. As you go for a safari, you find different kind of creatures. Similarly, what are different kind of applications of Ilizarov and hexapod? Just few of them I'll try to show you so that you can get ignited or you get stimulated, or you are ready to opt for this methodology, Ilizarov methodology. Compound fracture both one leg. I think every beginner in the Ilizarov methodology should start with the tibial frames. And this is one of the indications. Most of the orthopedic surgeons, they come across such kind of cases, compound fracture both bones of the leg. And Ilizarov is an indication for both bone leg compound fracture. And along with other things, this is also one of the things which can be done. And you see, everything is in alignment, everything is in position, and fracture has united. Let's go to slightly difficult case. This is a case of non-union in malposition. Initially, the leg vascular repairs they were done. It was a roadside accident, and more than 10 months have passed once this patient came to. His age 27. Preoperatively, frame with the hinges is the basic thing in Ilizarov. Preoperatively, you have to prepare. You have to see where the piece should go, where are the vessels, like in this case. I did angiography so that I can pass my pins in the direction which will not encounter neurovascular structures, which are deformed due to initial injury and repair. And also preoperatively, I fix the rings in deformed position so that once deformity is corrected, they are parallel to each other. After correcting the deformity, with the help of hexapod, the limb is very well aligned, is bearing weight, and fracture has united. Whenever in lower limb, most of the time, you are watchful not only for fracture union, but also for the proximal and distal joints, whether they are aligned or not. Also, the mechanical axis of the whole of the lower limb, whether it is well aligned or not, in both planes, rather in all the three planes, frontal, sagittal, and rotation. Dear friend, again compound fracture of the thigh. These are very much valuable indications for treating the case with the help of Ilizarov. The wound debridement was done and a bone cement was put. Instead of any internal implant, we used Ilizarov. And this was the final closure of the wound. These are day 1 X-rays, day 55 X-rays, day 100 X-rays, and these are the results 3 years post-operative. The fracture is very well aligned in both AP as well as lateral views, and these are the functional results. Again, we come to the leg, lower end, where lower part of the tibia and fibula, fracture subluxation of the ankle is also there. And if you see these bones, they are not normal because of some congenital issues. present already, and these were very osteoporotic bones that are bones. I just dissected across the ankle, and close reduction of the fracture was done, and the frame was built up. Fixation of the fractured pieces with olive wires and plain wires was done. The same patient, and these are the post-operative results. These are 9 years post-operative functional results of the patient. Patient was having flat foot already prior to the injury on both the sides. Another area, fractured distal end of the tibia, where the fracture lines, they are even extending into the joints, and soft tissue issues are there. If you are always scared, sometimes that some kind of skin issues, soft tissue issues, or other complication might not take place. These are the cases where Ilizarov is a boom. And another thing, case, fresh compound fracture with neurological deficit in the upper third of the tibia. There was lateral popliteal nerve palsy as well in this case. We did wound debridement, Ilizarov application with bone grafting. Ilizarov is one of the methods which gives you post-operatively an area to play. What does that mean? It is a modular situation. What does that mean? This means you can still play about the position of the fragments. Like in this case, if we can slightly displace the distal fragment laterally, there will be less tension on the lateral popliteal nerve. This is about the frontal plane. If we see carefully, the plateau in this case was directed reverse from posterior to anterior downwards. We want posterior to anterior slope, posterior PPTA, posterior proximal tibial angle about 80 degrees. So we can do this thing in spite of the fact that operation has been done. Still, we change the parameters. How? This is done with the help of head support. In the AP view, from yellow position to the red position, because we just want to translate it later. And in the lateral view, we want to create a flexion deformity so that plateau can be put into the desired position. You just have to direct the head support so that both the corrections can be done in one. And these are the post-operative results. The lateral popliteal also recovered luckily in this case, and plateau is also, PPTA is less than 90. And after application of Ilizarov, initially it was more than 90. Another case, 1.5 month old community fracture of the leg. You can see the skin conditions not very good. There is recurvator. There is large area of the fracture bone. Along with there, in the frontal plane, there is medial translation with angulation. We applied Ilizarov, and after that we applied the head support and corrected both planes, frontal as well as sagittal. No more angulation, no more translation. These are the results after. Again, tibial frame, upper end, intra-articular fractures. These cases, they are notorious, sometimes due to skin and soft tissue conditions. And if you are scared, you can use Ilizarov. Like in this case, we did because this was an intra-articular fracture, upper end of the tibia with medial condyle split fracture in coronal plane. We just reduced those fractured pieces with the help of wires, held them, applied poly wires and plain Ilizarov wires, and this is the condition. And dear friend, these are 8 months post-operative. You can see knee bending without any implant, which is inside, and good post-operative results. If you know this methodology, Ilizarov, facts apart, dear friends, you can have lateral thinking as well. What does that mean? Lateral thinking. Lateral thinking means this is a fracture in a poliotic. You can plate it, you can nail it, you can traction or spica, anything. But if you know more about Ilizarov, more about hexapod, more about deformities, you will find that there is FFT at the knee, which can be resolved by a supracondylar posture. So with the Ilizarov, the same time with which the fracture will unite, you can also correct the deformity and change the life of the patient. So we applied Ilizarov, corrected alignment of the fracture as well as corrected the deformity of the knee by doing it supracondylar posture. This is hexapod for the correction of the fracture. The same Ilizarov, this is hexapod for the correction of the supracondylar posture. And you can see from yellow to red, we have directed that this bone fragment from yellow should come to red so that angulation, extension, osteotomy can be done at the osteotomy. And these are the results. The same time which had to be taken for the fracture to unite, we have also utilized that for correction of the deformity, same bone at 2 places. Another example of lateral thinking is bilateral fracture calcaneum. In these cases, patient cannot go out of the bed for at least 1.5 to 2 months. But if you know this methodology, the next day after the operation, patient can be walking with the help of a walker, which can be done by just applying a shoe to the dummy ring and bypassing the area of fracture. So, dear friends, fracture is getting reduced as well as patient is mobile. I do not say that calcaneal fracture should always be treated by this, but it is a lateral thinking. You can give this benefit to the patient that from the next day after the operation, without any risk of the skin or soft tissue, with implants later on still put into the bones, fractures, sites, patient can be mobile. Another indication. Another indication is that Ilizarov reconstruction. 22-year female. Again, most of the cases where the deformities are also to be assessed, preoperative planning should be there. And very seriously, the more serious you are in preoperative planning, execution will be accurate, more precise. And as you keep on learning, you will keep on adding to your results. So I'm not going into details, but these are the frames which are made preoperatively. Their hinges, where they will be placed, the hinges placement, and postoperative X-rays. And then how to medialize the distal fragment. We did it with the help of hexapod, and these are the final results after 1 year. Dear friends, if there are multiple deformities in multiple planes in the same bone, like in this case, you have procurvatum, varus, shortening, proximal tibia, and again, preoperative planning. This case was done many years ago, about more than 16, 17 years back, when we used to treat these things with the hinges. So placement of the rings, how the hinges they are to be placed, first paper planning, then before autoclaving the Ilizarov apparatus with hinges, and again putting it to the patient where the pins will go, the placement of the pins, placement of the rings, everything is crucial. You have to just sit by the patient. And these are after application and after correction. Before correction, after correction. And these are the post-operative and pre-operative. Length has been gained as well as the deformity has been corrected. And dear friends, these are preoperative X-ray, AP, leg, and these are the postoperative X-ray leg, AP as well as lateral views. Another case, leg frame, Genuvarum right. These are the results, 7 months. And once you take the X-rays, full length X-rays in these cases, you will find where are the deformities, lower end of the femur, upper end of the tibia, upper end of the lower end of the tibia. In this case, the deformities, they were found to be upper end of the tibia and lower end of the tibia. And at both the levels, osteotomies they were done, and you can see post-operatively full length AP frontal plane and lateral sagittal plane. They are very well maintained, and no ugly, unwanted deformities of correction have been added during the correction. What does this mean? This means the deformities are mainly frontal plane deformities, as you can see, lower end of the tibia and upper end of the tibia. You start correcting that, you are only and only seeing the frontal plane. By the time you end up after 6 months, 1 year, you take the X-ray and you find, oh, sagittal plane is showing some deformity which you never wanted, unwanted deformity. So you have to take care that while resolving one plane, you are very cautious. You are not disturbing the other plane. This is a lesson which I came to know years after the start of my these cases of deformity. Another boon, Ilizarov methodology, is to correct infected non-union of the femur. This patient came about 16 years back to me, and he was having infected plate at the lower end of the tibia, lower end of the femur, and at many places he was advised amputation. So we removed the implant, removed all the dead necrotic material, applied Ilizarov, bone cement placement was done in the created cavity, and it was removed about 6 weeks after, and bone grafting was done, mesothelitic. And these are 10 years after the operation. There is no discharge, and bone has very well united. This infected non-union tibia femur has become now a specialized branch in treatment. Ilizarov methodology has given rise to many branches, and nowadays on the topmost branches is non-union of the leg or the tibia where Ilizarov is approved, and it is a specialty in itself. And most of the patients, they want treatment very near to their houses. And there are Ilizarov surgeons, very good Ilizarov surgeons. We are opting for these methodologies and treatment. Another 28-year male who sustained injury 12 years back and had fractured femur and leg. And supracondylar osteotomy, just distal to the prior malunion of the femur was done, and the limb was aligned. These are the X-rays 4 years later. This tibia was still to be addressed, but tibia united much more efficiently as the limb was put in mechanical axis, and he never turned up for his tibial correction. Another field, HTO, high tibial osteotomy, or we should nowadays term it as preservation of the knee joint, or osteotomies around the knee joint, so that instead of going for replacement, people can opt for osteotomies. For example, this young man of 64-year male, he was a runner, and now he started having pain on the left side, and he was to be operated upon for replacement. Somebody told him about me, and you can see Ilizarov is a boon, especially once both the planes are in the frontal sagittal. And you can see how friendly he is with the Ilizarov. This is the beauty of the Ilizarov patient. They can resume their work once the bones they are still in union. He is another patient where the right lower limb was affected and high tibial osteotomy was done. The deformities, they were in both the planes. Another field is genu valgum, both lower limbs. In this case, first left side was done. We found femur is at fault at two places, tibia also at two places. So first we did left side. After that, the right side. The left side was corrected with the help of Ilizarov and hinges. The right side was corrected with the help of Ilizarov and hexapod. These are the preoperative and these are the postoperative. You see, as you move towards more precision, from hinges towards the hexapod, the corrections they are much better. One thing. Second thing, with the passage of time, you keep on learning. We did first left side, then the right side. You see, right is much better place than the left one. These are results after many years of this injury treatment. Another genu valve, only left side. Corrected with the help of a supracondylar. This is genu valgum. Just I want to share one thing. When I was a postgraduate student, in those days, valgum was considered mainly a femoral issue. The deformity we thought is always at the femur. And if it is varus, it is at the tibia. Now the things have changed. We have many, many methods at our disposal with which we can find out really the deformity is at the femur or the tibia. So that we can attack that very part of the bone. If it is at the tibia, we do tibial correction. If it is at the femur, we do femoral correction. And if it is at both, we do both. And this is genu vera, hexapod, both the sides. And these are postoperative. Again, is a post-septic knee with shortening. And the knee was completely destroyed. Full extension was not possible. So we corrected the alignment in frontal as well as sagittal plane. Along with that, we did lengthening at three places, and these are the results. Again, collateral thinking. He is a boy, 15-year-old male. He had chronic osteomyelitis with equinus ankle. We did sarcorization to treat the osteomyelitis as well as we did correction of the ankle deformity from equinus neutral 2 to 3 degrees of equinus. These are the results 4 years after the injury. And dear friends, another field where I don't think anything else is better than Ilizarov is CTED, congenital talipes equine. At the 5 year of age, we corrected both the sides. And these are the result 11 years after the operation. Again, another girl at the age of 5 years came to us. She was already operated on. And you can see preoperative left side as well as post-operative. And after 4 years, once we requested her to send the pictures, they sent this video, the functional video of this. Is another boy, about 11 years of age, treated by multiple operations. Heel in varus, equinus, forefoot adduction, cavus. These are the results, both the sides after the Ilizarov correction. He's an this is a boy of CTV with various cavers, and at the age of 8 years, and heel bearers, cavers for food production. These are the results after 8 years of the surgery. Another 13-year-old male, CTV, with equinus, varus heel, cavers, adduction forefoot. And these are the results at the age of 20 years, 7 years after the surgery. Another adult, 24-year-old, treated many times earlier with the surgeries, open surgeries. And first one side, then another side. Corrections, they were done by supramalleolar osteotomy as well as foot osteotomies. And treatments, they were aligned with the help of two egg supports. You can see equinus almost corrected, forefoot reduction corrected, and foot lengthened. And these are the results. Another CTV, adult, this left side, oh, equinus, cavus, forefoot reduction, and these are the results after the surgery. As we have moved from very beginning, very simple kind of Ilizarov applications, now we are moving on to multiple levels, which are life-changing. These people are suffering from polio, hand-thigh gales, and with shortening in poliotics, with hand-thigh gales, with the limbs which are hanging lower limbs, never touch the ground with the involved lower limb. And they are walking without any stick, without any caliper or shoes. This is due to multiple osteotomy, their correction with the help of Ilizarov, lengthening with the help of Ilizarov, and these are the X-rays about 14 years after the treatment. Again, life-changing. The way of style, the kind of gait, so awkward, so energy-consuming, so tiresome, just going to post-polio syndromes with so big sticks, with calipers. One thing I will like to share with you in this, there is caliper with deformities and calipers without deformities. There's a big change. And again, age is not a big bar. 38 years, treated about 10 years back with the help of Ilizarov and hexapone. A girl who was walking with the help of a crutches initially, and with surgery, she could walk without any crutch. He's a doctor by profession, this young man, hanging lower limb. About 1 year later, he's walking without any caliper, without any shoes. Still physiotherapy is going on. And another hanging lower limb, about 1 year after, no shoe, caliper, stick, no sport. This is the beauty of Ilizarov. Ilizarov and hexapod is a subspecialty in orthopedics. But I think nowadays subspecialty has also been created, like non-union, infected non-union, as I told you. Another is polio. It's very time consuming to understand the pathologies, whether they are at the bone, one side or both the side, how much is the muscle power, how much we can treat in the single case, how much later is to be treated, how long it will take. Doesn't matter. Once you create an interest, you will create your own sub-specialties of Ilizarov and start enjoying. She came from UK just for treatment. And it gives you a different kind of pleasure and satisfaction that this patient left the whole world, came to India, stayed with me in my hospital for about 3 months. But this has really changed from 2 crutches to no crutches. So, dear friends, Ilizarov is changing lives, not only of the patients, also doctors like me. We are finding a new life. Once the patient gets a new life, it is another new life to us as well. These are the things can can only be done precisely with the help of Ilizarov. To learn Ilizarov and Hexapod, there are no patients. As you see, the corridor is almost empty. But just wait. If you have patience, they will start dropping. They will start coming. There are limbs, there are indications, and there are patients. You change their life. They change your life. They change your perspective. They give you a different kind of satisfaction or joy. Thanks a lot. If I had been a little contribution even to ignite you towards Ilizarov or hexapod methodology, I think the purpose of this presentation is met with. Thank you very much, dear friend, for sparing time for me and yourself and for the patient. Thanks.